Good to start, sir.
Okay. So, start. 3, 2, 1, go. A very good evening to all these students who are joining in for this INI CET RDx Pediatric series. I'm your pediatric faculty at Dr. Tutorials. My name is Dr. Sandeep Sharma. I've done my MD Pediatrics from PGI Chandigarh, and for the last almost a decade now, I've been training students for these exams. So, first of all, I'm taking this session at a difficult time for our country, and yes, we are with our army, our navy, our air force. We are with all the people who are protecting us at border so we can lead our daily life. So Jai Hind, first of all. Second thing, uh, work must go on. They are doing their job and they are doing it pretty well. It is our duty to continue with our job, which is to prepare, be better doctors, and be available for the country in the coming years as healthcare professionals. That is what our aim is, and that is what we are going to continue. What has happened right now is the session, it was supposed to start at 8 p.m. Right now in my watch, it is about 6:54. So it's about 1 hour, roughly 1 hour before I'm recording this session. Reason being, I stay in Chandigarh and my home is almost a stone throw away from airport. The airport has been closed. It's a high risk area, and we have got notification, and there was also some people who like government people who have requested us not to turn on any lights, including the inverter, generator, and solar lights at our places. And because my home lies in that high sensitivity zone, and yesterday also there was a drone attack, so we have been requested. And being law-abiding citizens, we all must, abide by the rules and regulations of the country. So I am recording this session. I'm not canceling it. I'm recording it 1 hour prior. It will go live as you are watching this session on YouTube right now. Right now, I'm sitting in the comment box. Any doubt you have, I will be answering, but unfortunately, it's 1 hour delayed because of reasons beyond our control. So let's support the country as well as let's support our work, that is exam preparation. So let us start with the INI CET question number 1. Question number 1 says, which of the following is the weight gain pattern for infants aged 3 to 12 months? The answer to this question, you might have solved it already, many of you who took this test on the app. The answer to this question is C, that is 400 grams per month. The topic that we are going to take up, the topic selection is based upon the current trends in INI CET. So 20 topics which I've taken, which I've put into the MCQ, they are all high yielding topics. We have limited time, so I'll try to cover as much ground as possible. The heading, the topic I'm going to discuss is weight gain pattern. Weight gain pattern in the first year of life. Whether you have prepared this pediatrics with me or you have prepared pediatrics from any other source, if you're a serious aspirant, especially targeting INI CET or NEET PG exam, these 20 topic discussion will give you a bird's eye view. You can add these points to the notes. It will be a revision tool. And even if you are not targeting INI CET, although it is meant for INI CET people and NEET PG people, but if you are targeting some other exam like FMG or UPSC CMS, then also the topics are similar. So there is no harm in understanding these things. So weight gain pattern in the first year of life. Let us suppose the birth weight of a child is X. It can be anything, 2.5, 3, 3.5. In the first 7 to 10 days of life, every child loses weight. In the first 7 to 10 days of life, every child loses weight up to 10% of the body weight, up to 10% of the birth weight. So suppose birth weight of a child was 3 kg at birth. Around day 6 or day 7, if you check, the weight will be less than 3 kg. How much less it can be? If it is a normal child, it is a normal term child, it can be up to 10%. So up to 300 gram in a 3 kg child, loss happening in the first week is normal. This is because when a child is born, the postnatally, when the child was a fetus, there was some edema fluid. Postnatally, that edema fluid is mobilized. And the rate of loss of fluid is more than what the tissue is getting formed in the body. So every child loses weight up to 10% birth weight. That is normal. Around 10th day, by 10th day, the birth weight is regained. The birth weight is regained. So around 8 day of life, 9 day of life, 10th day of life, the weight will again become 3 kg if the birth weight was 3 kg. Beyond 10th day, till 3 months of age, the child will have actual weight gain. And the weight gain in the child will be roughly between 20 to 40 grams per day. If you solve previous year questions, there is an older MCQ related to NEET PG that you will find being mentioned there. So weight gain 20 to 40 grams per day between 10th day till 3 months of age, you will find in the child. And lastly, if this, what the question is saying, between 3 to 12 months, from 3 completed months till 12 months, the average weight gain in a normally growing child will be about 400 grams per month. Whatever topic I'm discussing, these 20 topics, in addition, any PYQ comes across, I will be marking it here. At the same time, I will not spend too much of time because it's a revision session. So this is the weight gain pattern in first year of life. And these are the facts you need to remember. Apart from these facts, if I'm an examiner and you have understood the concept, I can check you. I can check your knowledge. How I can check your knowledge? Let me give you some example. Example number one. Birth weight of a child was 3 kg, term baby. Day 5 of life, weight found to be 2.8 kg. Is it normal? Yes, the answer is no. Because birth weight up to 10% in the first week of life is normal. Birth weight was 3 kg at birth. Birth weight was 3 kg and day 8 of life, day 9 of life, weight is again 3 kg. So parents will say no weight gain is happening. But is it normal? The answer is again, child has regained by 10th day, birth weight is regained. In a term child, the regaining of birth weight is slightly rapid. In a preterm child, sometimes it can be delayed. Third scenario, birth weight of a child was 3 kg. On day 5 of life, weight was found to be 2.1 kg. Is it normal? So weight gain has happened, but 900 grams loss has happened. 900 grams divided by 3000 grams. It's almost 30% loss. This is not normal. Child is not growing well. Child is dehydrated. Child is not feeding well. Evaluate the child, admit in hospital and evaluate. So more than 10% loss in a term child in the first week is not normal. Scenario number 4, which can be asked to you in the exam. Birth weight 3 kg. Day 5 of life, weight found to be 3.6 kg. Is it normal? Parents will be very happy. Child is gaining weight. No, there should be weight loss happening in the first few days. If weight gain is happening instead of weight loss, it indicates fluid retention or edema happening in the child, right? So how to remember these scenarios? This topic can be asked in multiple ways. The fact-based thing, which is given in OP Grade 10th edition, I have mentioned it here. You can write scenarios. Scenarios. High-yielding topic, I will spend more time. Fact-based question, I will go faster. Scenario, if weight gain occurs in first week of life, that is always abnormal. And what will it indicate? Fetal edema. Sorry, it's not a fetus. It will indicate neonatal edema. What are the possibilities you will consider? Rule out renal cause, rule out patent ductus arteriosus in the child. These are the two important causes you will rule out. Patent ductus arteriosus can cause congestive cardiac failure in the first week of life. If there is weight loss, any weight gain was abnormal, weight loss up to 10% in the first week of life, that is considered to be normal phenomena. Nothing needs to be done. Weight loss greater than 10 to 15% in the first week, it is abnormal. It indicates dehydration in the child or poor feeding. Mother's milk is not being given to the child. And weight gain, weight of the child exactly equaled birth weight between 8 to 10 days of life, it will again consider to be. So if I'm an examiner, I want to push the boundary. These are the concepts I will be checking in. If you have understood these points, these facts, and the scenarios which can be asked, you are ready with the topic. These scenarios, if you go into the older questions, you will find similar scenarios being there. But the issue is most of us don't have time and we only do MCQ starting from 2019 or 2020 onwards till about 2024. That is the way to go. But this additional point you need to add to the notes. So the topic is, which of the following is the weight gain pattern for infants age 3 to 12 months? Answer is C, 400 grams per month. And this is the answer. And this is the explanation. Please, whatever source you're following, add it to your notes. Knowledge in a high-yielding topic never harms. Let's go to the second question. Arrange the following development milestones in the order of their appearance in a normal child, starting with the earliest and ending with the last milestone to be attained. And this question I have created This is a question I created myself for all of you. If you find it bad question, apologies. But giving options and asking them to arrange in ascending or descending order is one of the ways INI CET people ask you. And it is a tough question. Anyway, development milestone is a tough topic. Questions like this, you need to have high accuracy and you need to apply a bit of common sense to reach the correct answer. Negative marking is there, but if you get it right, questions like these are rank deciders. So let us go one by one and try to see if you get a question like this, don't look at the options. First, look at the upper things which have been given to you, and then we look at the ABCD option. They are asking about the milestone, and we have to find the earliest and the last milestone in proper order we have to arrange. What is pivoting? Pivoting means rotation of the body, ability to rotate the body and reach out for the object. Pivoting, in bracket I'm writing rotation in axis. This is a milestone which generally comes around 10 to 11 months of age. Partial pivoting can come as early as 7 to 8 months, but true pivoting, that is rotating the body in a sitting position, that comes around 10 to 11 months of age, according to Opighai, as well as Nelson 22nd edition, as well as Illingworth. So pivoting 10 to 11 months. Unidextrous reach comes at about 6 months of age. There are two types of reach you need to know. If the child approaches with both the hands, that is bidextrous reach, which comes at 4 months of age. And unidextrous reach is approaching with one hand, that comes at 6 months of age. Then is speaking first real word, which comes at 1 year of age, that is 12 months. And making a train using colored blocks. Now, there are two things you need to understand. When the child makes a vertical tower using colored blocks, this is called as tower making. When the child arranges objects like this is called as train making. Important and interesting thing to note, tower making comes earlier compared to train making. We tend to think that tower making will be a difficult milestone. No, brain develops in such a way that vertical milestones come early compared to horizontal milestones when the child is stacking the object. It is a fine motor milestone. So first child is able to make tower of 2 cubes, then tower of 3 cubes, and so on. These are the milestones which you must have read. You are supposed to revise them. What is train making? Train making, where the child makes a train like this, that comes at 2 years of age, and that is what you will be writing. Now, if you have to arrange, now which is the first one to come? The first one to come in the child is unidextrous reach. So 2 will come first. Then you will have pivoting coming, that is 1. Then you will have speaking first real word, that is 3. And in the end, making a train will come 2, 1, 3, 4. That is C option. That is your correct answer. This is how you are supposed to solve. My suggestion to you, have some time. Questions which are easy and one-liner based, mark them rapidly, because questions like these are going to take time. So keep some time spare, and you should have precision in topics like milestone. I don't know how it works. If you read milestone, they get asked in the they don't get asked in the exam, but if you leave them, somehow they get asked. So the best way for milestone is do them in moderation and do from one source. Eat what you can digest and read milestone what you can revise. If you don't revise milestone, you will not be able to recall them in the exam. And one more thing I want to emphasize, examiner can show you photograph like this and ask you, when do these milestones come? This is called as train making, where horizontal stacking is being done. It comes at 2 years of age. When the child makes a train, that is horizontal stacking, and also tries to raise a tower at one end, this is called as train with chimney. These milestones are given in Opighai, but they are not given in the table. They are given in the blocks or in the text, which is something that we don't read. Examiner puts questions sometimes from that. Train with chimney comes at 2.5 years of age. That is 30 months of age, and that will be your answer. So keep in mind, this is train with chimney, right? Let us go to question number 3. Question number 3. Similar question has been asked in 2024 exam. I have taken same topic, similar question, but a different variety of question. I'm quite sure you have gone through the previous year questions of INI CET. Similar question you will find there. We will be doing a conceptual flowchart based approach. If you have not done this topic, mark it, write it somewhere. It will be handy, not only for your INI CET, but for the next NEET PG exam whenever it might come. So question number 3, an 8-year-old child is being evaluated for short stature. His height was found to be 110 centimeter with sitting height being 70 centimeter. What is sitting height? Sitting height is nothing but upper segment. Which of the following can be the likely cause of short stature in this child? For a question like this, there is a way to approach. First of all, you should know the normal upper segment to lower segment ratio. What is upper segment? In you and me, these are the normal values that we first need to know. Only once you understand normal, you can understand the abnormal. From crown of head to midpoint of pubic symphysis, we call it as upper segment. From midpoint of pubic symphysis till sole of foot is called as lower segment. In you and me, normal people, normal adults, the lower segment is bigger and upper is smaller. But when a child is born, the upper is bigger and lower is smaller, and there are ratios in between that you need to know. So at birth, the upper is bigger than lower by a ratio of 1.7 ratio 1 to 1.9 ratio 1. At 3 years, the ratio becomes 1.3 ratio 1. Between 6 to 7 years, the ratio becomes 1.1 ratio 1. 8 to 10 years, it becomes 1:1. Some of the books say 7-year 1:1. No, OP Gai, as well as majority of books, including Nelson, also says that beyond 7-year 1:1 is attained. And Indian textbooks say 8 to 10 years as the range. So this is what we are going to remember. And beyond 10 years, adult ratio is attained. And what is the adult ratio? In you and me right now, 0.9 ratio 1. Pehla cheez ye hai, this can be asked as standalone MCQ also. Now, what are the types of short stature based upon upper segment, lower segment ratio? What is short stature? Definition you must have read already if you have revised pediatrics. Height for age below -2 standard deviation or height for age below third centile. Many times, short stature is divided into multiple categories depending upon body proportion. So whenever a short stature child comes to you, you will look at the upper segment, lower segment ratio in that child. Now there are two possibilities. Either the upper segment, lower segment ratio is appropriate for age. Jitna hona chahiye utna hi hai. It is appropriate what it should be, or it is not appropriate for age. If it is appropriate for age, it is called as proportionate short stature. Yani ki body proportions are normal for that age. Not appropriate for age is called as disproportionate short stature. What are the causes in which proportionate short stature is seen? All the conditions which are having physiological short stature. If you have gone through the topic, you will know that there are short stature which are physiological short stature. Example, constitutional delay in growth. That is considered to be proportionate short stature. These are the patients who have delayed puberty. They have short height, but they tend to show catch-up growth. They have a good outcome. It's a very, very common condition. And second is familial short stature, where there is a strong family history of short stature in the family. Familial short stature is also called as genetic short stature. Short mummy, short papa, short baby, that is familial short stature. Okay. So both the physiological short stature will always have body proportion normal. Second, growth hormone deficiency will also have proportionate short stature. Thirdly, malnutrition related short stature will be proportionate. And fourthly, chronic disease or chronic illness related short stature. Chronic illness related short stature will also be normal. So these are the 4 important causes of proportionate short stature you need to remember. What about disproportionate short stature? If the upper segment, lower segment ratio is not appropriate for age, you will see what exactly is the problem with that upper segment, lower segment ratio. There are two possibilities. Upper segment, lower segment ratio is abnormally high. For example, it should be 1:1, but you find it is 1.3 ratio 1. So usko kahenge upper segment, lower segment ratio abnormally high. Because upper segment is very big, lower is small. So the lower means legs are small. So these are also called as short limb dwarfism. And second possibility, upper segment, lower segment ratio is abnormally low. These are called as short trunk dwarfism. You have to remember what are the causes of short limb and short trunk dwarfism. Let us write them down. Short limb dwarfism, typical example, achondroplasia. Another example, osteogenesis imperfecta. I'm just writing in short. Skeletal dysplasias generally have short limb dwarfism. Rickets, it is a disease of growing bone. Bone will not grow, short limb will happen. And fourth, hypothyroidism. Severe congenital untreated hypothyroidism will cause short limb dwarfism. Causes of short trunk dwarfism. You will have a condition called as spondyloepiphyseal dysplasia. Then tuberculosis of the spine will have short trunk dwarfism. Hemivertebra, a defect, a congenital defect, will have short trunk dwarfism. Lastly, Morquio syndrome. Have you heard of Hunter syndrome, Hurler syndrome? They are lysosomal storage disorders, mucopolysaccharidosis. उन्हीं का एक ब्रदर है, उन्हीं का एक फैमिली मेंबर, Morquio syndrome. It is MPS4, mucopolysaccharidosis type 4 will also have short trunk dwarfism. So these are the other causes that you need to know. You can get a standalone one-liner question also from this classification. This is very important. Now let us go back and try to analyze the question. So we have discussed a normal upper segment, lower segment ratio. We have discussed this classification. Let us go back to the question. Look at this question. How you are going to approach questions like this. Approach is important. First of all, when they are asking you a question like this, look at the age of the child. So at 8 years of age, what is the normal upper segment, lower segment ratio? You tell me what is the normal upper segment, lower segment ratio. By 8 years, it should be roughly 1:1. Okay, this is what we did. In this patient, what is the upper segment, lower segment ratio given? Let us calculate. Total height, 110 centimeter. Sitting height. Sitting height is the other name. Remember, sitting height is the other name for upper segment. So upper segment is 70 centimeter. So what will be the lower segment? 110 minus 70, that is 40 centimeter. So what will be the upper segment, lower segment ratio in this patient? It will be 70 by 40. It comes out to be 1.75 ratio 1. Compare these two conditions. In this patient, upper segment, lower segment ratio is abnormally high. And if it is abnormally high, what kind of short stature are we looking at? Short limb dwarfism. Now go to the options and look at which is the cause of short limb dwarfism. Constitutional delay in growth? No, it is a cause of proportionate short stature. Spondyloepiphyseal dysplasia? No, it causes short trunk dwarfism. Growth hormone deficiency? Again proportionate. Achondroplasia, that is your answer. So remember upper segment, lower segment ratio. Apply the rule, know the classification, get into INI CET, get into AIMS, get into PGI, get into JIPMA. If you want to go to Central Institute, the path is not difficult, the path is just tricky. You should know the approach to such questions. Now, keeping this in mind, practice more question, also solve the May 24 INI CET recall question. The way you look at the question, that perspective will change. So this recorded version of this video will also go up. In case you have any doubts, you can always reach out to me. I will share my Instagram and details also with you. But the only thing is, just remember the approach. I've taken full 10-12 minutes to discuss this. Trust me, it's totally worth it. Let's go further. Question number 4. Increased pulmonary blood flow is seen in which among the following congenital heart diseases? Again, similar kind of question. You need to remember the classification of congenital heart disease according to pulmonary blood flow. You can divide them into acyanotic and cyanotic. You can divide them into LV enlargement versus RV enlargement. Sometimes radiologists are very fond of this. They classify the diseases according to pulmonary blood flow. Whenever there will be increased pulmonary blood flow, that is called as pulmonary plethora on X-ray. Whenever there is decreased pulmonary blood flow, there will be pulmonary oligemia on X-ray. So let us understand, how do you divide congenital heart diseases? I am giving the heading congenital heart diseases according to pulmonary blood flow. According to pulmonary blood flow. Pulmonary blood flow means how much blood flow is going into the lungs. From pulmonary artery, from right ventricle into the lungs, how much blood is going. You can have increased pulmonary blood flow and you can have reduced pulmonary blood flow. Increased pulmonary blood flow will produce chest X-ray, will show pulmonary plethora. Pulmonary plethora means bronchovascular vascular markings will be prominent. White lines it will show. Decreased pulmonary blood flow, chest X-ray will show pulmonary oligemia. The vascular markings will disappear. X-ray will appear very black. That is pulmonary oligemia. Increased pulmonary blood flow, it is seen in all left to right shunt lesions. Do you know any left to right acyanotic shunt lesion? Example, ASD, VSD, PDA, ECD. ECD is endocardial cushion defect, which is a disease of Down syndrome. Pulmonary blood flow is increased. Then TGA, transposition of great arteries, increased pulmonary blood flow. TAPVC, total anomalous pulmonary venous connection, increased pulmonary blood flow. Truncus arteriosus, also called as persistent truncus arteriosus, pulmonary blood flow is increased. Lastly, single ventricle physiology, blood flow is increased. Decreased pulmonary blood flow is seen in right to left shunt lesion. Example, right से left में चला गया ना, तो right ventricle से blood will go less to the lungs. Example, the typical example, TOF, tetralogy of Fallot, the common cyanotic heart disease, pulmonary oligemia, where you see boot-shaped heart. Not just boot-shaped heart, you also see pulmonary oligemia. There will be Abstein's anomaly. Abstein's anomaly is the condition where pregnant lady takes lithium and the baby gets heart disease. It will be seen in tricuspid atresia. It will be seen in pulmonary atresia. There is a defect known as Eisenmenger syndrome, where also pulmonary oligemia can occur. Eisenmenger syndrome is a complication of non-treated long-standing VSD and PDA, where reversal of shunt can happen. So these are the causes you're supposed to remember. And look at the options now. Increased pulmonary blood flow is seen in which of the following congenital heart disease? TOF, no. Abstins, no. TGA, yes. Tricuspid atresia, no. TAPVC, yes. So 3 and 5, C is your answer. Okay, and just have a look. This is how pulmonary plethora will look like. Can you see in this condition, pulmonary plethora, increased vascular markings? Can you see increased vascular markings? I'm zooming in. This is how pulmonary plethora looks like. And due to increased pulmonary blood flow, many of them will have congestive cardiac failure symptoms. On the other hand, this is how pulmonary oligemia looks like. Can you see abnormally black shadows have appeared in the patient? So pulmonary oligemia will look something like this. Compare the two X-rays. You can easily see increased pulmonary blood flow, decreased pulmonary blood flow on chest X-ray. Okay, let's go to the next question. Question number 5. Which of the following is used to monitor response to therapy in a patient of severe congenital CMV? Congenital CMV, congenital rubella, congenital toxoplasma. High yielding topics, so very important for INI CET as well as NEET exam. Go through them properly. So there is a patient where you don't want to make the diagnosis. You want to monitor therapy in Gansec if the patient is being treated with Gansec. Okay, so let us do a quick review of the diagnosis of congenital CMV. Diagnosis of congenital CMV. First of all, what will be the clues given in the question? The clues will be, there will be, examiner will say rash, IUGR, and most importantly, periventricular brain calcification. Periventricular brain calcification. And last but not the least, HSM, hepatosplenomegaly. Among them, this is the most important clue that will be given by the examiner. This will be the clue in the question. Okay. Then what are the investigation that you will do? First of all, can you do ELISA for IgM and IgG? They can be done, but they have low sensitivity. They have low sensitivity. Second, what is the investigation of choice? Investigation of choice is PCR for CMV detection. It is commercially available. If they ask you screening के लिए करना है, तो for screening purpose, the best sample is saliva. But for diagnosis, confirmation of the diagnosis, best sample is urine. Blood is used sometimes, but it is not a good sample for CMV detection. And if they ask you gold standard investigation, that will be urine culture for virus isolation. Urine culture for virus isolation. And there is a special technique which is employed for that. That technique is called as shell vial technique. The examiner will not ask you details. Shell vial technique. And fourthly, to check response to therapy. To check a response to therapy. You have started ganciclovir. You want to see whether ganciclovir is effective or not. You will check the blood. Now, this is a blood investigation for an antigen known as PP65 antigen assay. This is commercially available in our country. right? So these are the tests that you want to see, that you want to do in the patient. Apart from that, if you do neuroimaging, you will find periventricular brain calcification, and these patients require hearing screening because sensory neural hearing loss can occur as a sequela in such patients. If they ask you as a one-liner, overall best sample for CMV detection, congenital CMV detection, your answer will be urine. If they say screening, saliva. For response to therapy, PP65, which is a blood test. I hope you will not go wrong on this topic, at least in these points. These points taken from Nelson, Guy, as well as there is a standard textbook, Cloherty. Those who take MD Pediatrics or DNB Pediatrics, you will be buying that book on day one, along with Nelson. So the answer to this question, PP65 antigen level. Let's go further. It's an easy one, not to spend some time. Fact-based question. Arrange the following microorganisms in childhood pneumonia 5 to 15 year age group, starting with the most common. In the age group of 5 to 15 year in pneumonia, they are talking about childhood pneumonia. Most commonly, it is caused by Mycoplasma pneumoniae, followed by pneumococcus, that is Streptococcus pneumoniae, followed by Chlamydia member, known as Chlamydophila, followed by Haemophilus influenza type B, followed by viral causes. This is the sequence you are supposed to remember. Young child, see, newborn bacteria. Between 2 months to 5 years, it is the viruses like RSV which are common, adenovirus is common. But beyond 5 years of age, it is the bacteria and atypical bacteria which become more common. So what is the correct sequence? Correct sequence will be 1, then 3, then 2, and 4. 1, 3, 2, 4. That is B is your answer. If you have any doubts, table given in Nelson. This is the sequence in descending order. Mycoplasma pneumoniae, Streptococcus pneumoniae, Chlamydophila pneumoniae, H influenza type B, non-typeable, influenza viruses, adenovirus, other respiratory viruses, Legionella pneumonia. You get the answer. So remember this table, add it somewhere, taken from Nelson. For INI CET, you need a bit of Nelson. Question number 7, easy one. All of the following vaccines must be given before splenectomy, except कौन सा vaccine splenectomy से पहले नहीं देना? See, if a spleen is involved in protection from capsulated bacteria by the process of opsonization, and if spleen goes, there is a risk of capsulated organism infection. So the child should be protected from capsulated bacteria like pneumococcus. So you need to give pneumococcal vaccine. You need to give meningococcal vaccine. That is also a capsulated bacteria. H influenza is also a capsulated bacteria. You need to protect it. But typhoid is not, risk is not increased dramatically by splenectomy. And so typhoid conjugate vaccine by exclusion is your answer. And in all these patients, pneumococcal, meningococcal, H influenzae, even if you are giving vaccine, you should give in elective splenectomy. In elective splenectomy, if you're planning due to some splenic disorder or due to some chronic ITP, in elective splenectomy, the vaccination must be given at least 2 weeks prior to the surgery, because it takes some time for the response and the antibodies to be formed, right? Answer to this question by exclusion is D. Question number 8. A baby was born to a HIV positive mother who was not taking antiretroviral therapy. The baby was started on exclusive breastfeed. What should be the initial prophylaxis to start in the baby according to latest guideline? Now, we need to do a quick review of the NACO updated guidelines. The guidelines say what is HIV exposed infant? First thing you need to understand, any baby born to HIV positive pregnant female is called as HIV exposed infant. Suppose there is a HIV positive lady, she bears a baby comes into this world. What do we call it as? HIV exposed. We don't know whether baby is infected or not. We call it as HIV exposed. What feeding you will give? Exclusive breastfeeding is always preferred over exclusive replacement feeding, which is nothing but formula milk. And animal feeds and mixed feeds, generally they are avoided. Okay, can breast milk transfer HIV? Yes, but the risk is less provided mother is on ART, baby is given prophylaxis, benefit outweighs the risk, and so exclusive breastfeeding is recommended. And then all these HIV exposed infants are categorized into 2 categories, into low risk as well as high risk. How do we divide them? To save time, I've already made it for you. HIV exposed infants, low risk babies are those where mothers are having decreased viral load at 32 weeks of pregnancy. It is mandatory according to National AIDS Control Organization in India that every pregnant lady should undergo viral load testing at 32 weeks. If the viral load is low, less than 1000 copies per ml, these babies are called as low risk. And this will be possible only if the mother is taking ART. You understand? What is high risk? Any one out of these four. If the HIV positive mother is not taking ART, baby becomes high risk. HIV का होने का risk, infection होने का risk is high. Viral load testing was not done at 32 weeks, at or beyond 32 weeks, high risk. Maternal viral load not suppressed, your ART was failing, high risk. And HIV found within 4 to 6 weeks of delivery, late detection of HIV, high risk. So any one out of these present, high risk. Otherwise, by default, mother taking ART and she had low viral load, we call it as low risk infant. Now, what is the prophylaxis you need to give in? So I'm giving the heading ARV, antiretroviral prophylaxis in HIV exposed infant. What is the prophylaxis you are going to give? If it is a low risk infant, you will be giving oral nevirapine daily, starting from day 1 for 6 weeks. But if it is a high risk infant, you will be giving oral nevirapine. It's not a combination. Separately, you will also give oral zidovudin. So dual drug therapy needs to be given daily. For how much time? If exclusively breastfed, so you will give for 12 weeks. If exclusively replacement fed, that is formula milk fed, you will give for 6 weeks. And this is something you need to remember. The older concept of giving till 6 months is no longer followed. Very, very important. Add it somewhere you can remember. And also note that we always do PCR for testing in infants below 6 months. So PCR for HIV, total nucleic acid is done. Detailed guidelines we have discussed. I have discussed elsewhere. I also put an update on the social media sometime back, so you will find it. So read the HIV testing in infants. It's a high important thing, and also add it to your notes if you have not done so far. So now go back to the question. In this question, mother was not taking ART. So this is a high risk infant. He has been started on exclusive breastfeed, which is the right thing to do. Exclusive breastfeed, high risk baby, you give combination therapy for 12 weeks. That is your answer. Okay, add it somewhere. Let's go further. Question number 9. In a child with recurrent UTI, what is the order of performing investigation in importance on follow-up? What is recurrent UTI? What is recurrent UTI? Recurrent UTI is any second episode of UTI in childhood. Any second episode of UTI in childhood is called as recurrent UTI. Right? So any UTI patient, you need to do testing. All babies, you need to do, when the baby comes for follow-up, you need to do ultrasound KUB. If KUB is normal, no further testing is needed. But if you find that there is recurrent infection present or any abnormality, you need to do MCU. And this MCU is done after. This MCU is done after a delay. You will be delaying it by a gap of 2 to 4 weeks, according to the latest guideline. What is MCU? Micturating cystourethrogram. It is the investigation of choice for vesicoureteric reflux. You want to see reflux is happening or not. And after MCU has been done, if you need to do DMSA, the DMSA should not be done in acute phase. It should be done after 4 to 6 months. So the sequence of doing investigation will be first do ultrasound KUB, then you do MCU, and then you do DMSA. This sequence cannot be broken, and this is the sequence you're supposed to remember. So question number 9, the answer is first ultrasound, sec 1, 2, and 3. That is A option is your correct answer. Right? Let's go further. Question number 10. Term appropriate for gestational age infant girl is found to have girl, webbed neck, edematous feet. Webbed neck, edematous feet in a girl. You think of Turner syndrome. But hey, when you do karyotyping, 46 XX chromosomes are present. So this is not Turner syndrome. So Turner-like features, but normal karyotype. What will you think of? The patient is having a pseudo-Turner syndrome. And pseudo-Turner syndrome is also known as Noonan syndrome. Noonan syndrome can occur in girls, it can occur in boys. It's a misconception. People think Noonan sirf boys mein hota hai. No, Noonan syndrome can occur in males as well as female, and they occur due to PTPN11 gene mutation. And in these patients, the karyotype will be normal. So normal karyotype will be seen in Noonan syndrome. In fact, there is another MCQ if you practice older questions. The question was, all of the following conditions can be diagnosed by karyotyping except options were Down syndrome, Edwards syndrome, Turner syndrome, Noonan syndrome. Your answer was Noonan syndrome because 46XX. All the other varieties, aneuploidies, either trisomy 21, trisomy 18, monosomy X. So you will be able to find them. So answer to this question is B, that is Noonan syndrome. Right. Let's go further. Question number 11. Now we are getting into some speed. Question number 11. 2-year-old male child playing suddenly developed acute onset breathing difficulty. No history of such symptom in the past in the family. Chest X-ray shows unilateral hyperinflation of the lung. What is correct? Let me put it down form. Age less than 5 years. Child comes to you with sudden onset cough or respiratory distress. Sudden onset cough or respiratory distress with or without wheezing, or chest X-ray showing hyperinflation. Hyperinflation means over expansion of the lung, which is unilateral. The wheezing will also be unilateral. You should always suspect foreign body aspiration, and generally this foreign body aspiration has occurred into the bronchus, because if it is in the upper region, then it will cause choking, and you will have to do, if it is an older patient, Heimlich maneuver. Otherwise, you will have to do chest and back thrust, as has been taught to you in ENT by Rajiv Dhawan sir. So age less than 5 years, isko yaad kar lo. This will be very useful in all your case scenarios, including some in ENT, including some in surgery. So sudden onset cough or respiratory distress with or without unilateral wheeze, foreign body aspiration into the bronchus. Sudden onset cough or respiratory distress, chest X-ray showing unilateral hyperinflation, foreign body aspiration in the bronchus. तो क्या करना है? Perform immediately. You will perform immediately rigid bronchoscopy. Why? Rigid bronchoscopy is both diagnostic as well as therapeutic. It is both diagnostic and therapeutic. Flexible fiber optic bronchoscopy can be useful for diagnosis, but you cannot take it out. So what's the point? You will have to repeat the procedure, and invasive procedure will have to be done twice. Better क्या है? Use a rigid bronchoscope, right? Now, people often ask, sir, hyperinflation क्यों होता है? Now, it's a very important and interesting thing to happen. Try to understand. If a foreign body goes into the bronchus, there can be two possibilities. One, there is partial obstruction, as you can see here, which is more common, like peanuts go, they will cause partial obstruction, or complete obstruction can happen if the object size is almost exactly similar to the lumen of the bronchus, or slightly bigger, it will cause complete obstruction. More common is partial obstruction, but complete can also occur. If there is complete obstruction, if there is partial obstruction, first of all, the common variety, you can write most common, there will be ball valve mechanism. What happens here is, during inspiration, air can move inside, but during expiration, the air will be trapped. This is called as ball valve mechanism. So these patients will have unilateral wheeze, progressive hyperinflation, and breath sounds may be reduced, but they are not absent on the affected side. Complete obstruction, what will happen? Now there will be no air entry happening, and there will be no wheezing. Complete atelectasis or collapse on the X-ray, and absent breathing sounds on the affected side will be present. Treatment of both will be same, but two types of mechanism will be seen. Here, hyperinflation will happen. Here, collapse of the lung. Right? Both of the things you need to know. Now, with this in mind, let us go back to the question. So the diagnosis in this child is foreign body aspiration. You all know. Look at the options one by one. Possibility of laryngotracheal bronchitis. Croup should be considered. No, there is no stridor. Flexible bronchoscopy is the procedure of choice. No, it is a rigid bronchoscopy. Focal hyperinflation with the reduced or absent breath sound suggests foreign body aspiration. It is true. And hyperinflation is often produced by ball valve mechanism in complete obstruction. No, ball valve mechanism occurs in partial obstruction. Hyperinflation does not occur in complete obstruction. Collapse occurs in complete obstruction. So D option is also wrong. So answer to this question is C. It's very similar to actual MCQ asked in the past. It's a tough question. I wanted to discuss it with you. Many of the students I am connected with, they said कि सर इसके बारे में कोई update डाल दो. I thought, okay, let me put it in the INI CET RDx series itself. Who knows? Who knows? Let's go further. Question number 12. the pneumonia question, IMNCI guidelines. A mother brings her 9-month-old child to hospital for fever and cough. The child is having a respiratory rate of 48 per minute, no chest retraction, no other sign. What is the next step in management? What do the IMNCA guidelines say? Pneumonia diagnosis as per IMNCA guideline. पहला चीज क्या करेंगे? Any child less than 5 years of age comes to you with fever or cough, check for fast breathing or tachypnea. So less than 2 months, respiratory rate 60 per minute or more is tachypnea. 2 to 12 months, equal to or more than 50 per minute is tachypnea. 1 to 5 year, 40 per minute or more is tachypnea. Second thing, we check for chest indrawing or chest retraction. And third step, we look for general danger signs. There are 4 general danger signs you look out for. The general danger signs include stridor in a calm child. No, sorry. Really sorry. General danger signs include severe undernutrition, abnormally sleepy or difficult to awake. This is nothing but lethargy. I have to finish the session on time before the lockdown thing comes in, before the, not lockdown, the blackout thing comes in. So I'm going a bit slow, but not compromising on the points. So ignore my bad handwriting. My actual handwriting is good. It is better than what I'm writing right now. So normally sleepy or difficult to awake, then convulsions or seizures, and inability to feed or drink. Inability to feed or drink. These are the 4 danger signs that you will watch out. And then you will make the diagnosis. So 3 things you did: fast breathing hai ya nahi, chest indrawing hai ya nahi, general danger sign hai ya nahi. How you make the diagnosis? This is the IMNCA guidelines. Start from the bottom. No signs of pneumonia, no tachypnea, no chest indrawing, no danger sign, no pneumonia. Only symptomatic therapy needs to be given. Fast breathing or chest indrawing, but no danger sign, pneumonia, yellow code. This is green, this is yellow, this is pink. So pneumonia is there, oral antibiotic amoxicillin for 5 days and review the patient after 2 days. And if there is any general danger sign or stridor at rest, that is stridor in a calm child, or SpO2 below 90%, that is cyanosis, severe pneumonia, also called as very severe disease, first dose of ampicillin gentamicin, refer urgently to hospital if you are sitting in primary health center. If you are already sitting in AIMS Delhi or PGH Chandigarh, you will not refer, you will admit the patient and provide oxygen all the way to the hospital. It is your duty to do it. With great power comes great responsibility. You are MBBS, you are medical officer, you are referring the child. Make sure oxygen is there and working. Somebody to give the oxygen to the child is there. Many places you have those sham ambulances, those white Maruti Omni and ambulance written in reverse. And sometimes you see inside nothing is there. It is your duty to check. Oxygen is there, refer the child on oxygen. This is the management according to IMNCA guideline. Okay, now have a look at the question. Is there tachypnea in the child? No. 2 to 12-month cutoff should be 50 or more. So there is no tachypnea, no chest retraction, no other sign. So no pneumonia. Hence, no antibiotics are needed. Answer is A. Variations of this question can be asked. A different variation has already been asked. I've just tinkered with it a bit. Let's go to question number 13. All of the following are CFTR correctors approved for use in a cystic fibrosis patient, except hot topic, cystic fibrosis. What are the molecular agents approved for use? You know that cystic fibrosis is a multi-system condition where there is CFTR gene mutation. And now, as a part of gene therapy, you have CFTR modulator drugs which are available. CFTR modulators are those drugs which affect the functioning of the gene. There are 2 types of CFTR modulator. You have CFTR potentiator and CFTR corrector. What is CFTR? CFTR stands for cystic fibrosis transconductance or transmembrane regulator. It codes for a chloride channel. This chloride channel dysfunction is responsible for cystic fibrosis. CFTR potentiators are those drugs which potentiate, that is, make the chloride channel open. These drugs will be effective in those mutations where the channel is present but it is not opening. Example, it will be useful in a mutation G551D mutation. There is a mutation where chloride channel forms but it does not open. And so if you open it, the patient will be cured. The drug responsible here is ivacaftor. In fact, this was the first CFTR modulator which was approved for use. Then we have CFTR corrector. These are the drugs which make chloride channel reach the lumen, reach the surface or lumen of the cell. This will be effective in those mutations where CFTR protein, as soon as it is formed, it is degraded inside the cell and never reaches the surface. If it never reaches the surface, there is no CFTR channel on the surface of the cell. And this is seen, these characters will work in delta F508 mutation, also called as phenylalanine 508 deletion. The most common gene mutation, delta F508, where phenylalanine gets deleted at 508 position. It is also a previous year question. These patients, CFTR correctors, partially improve the functioning. Not fully, but partially they improve the functioning. And CFTR correctors include three category of drugs. You have tazakaftor, you have lumacaftor. All these drugs end by caftor, and elixacaftor. These agents are very costly. They are not easily available, but where possible, they have a improve the lifespan and quality of life in a dramatic way in cystic fibrosis patient. And generally, the commercial preparations combine ivacaftor along with one drug out of these three. They have synergistic action. So all of the following are CFTR characters approved for use in a cystic fibrosis patient, except ये तीन character है, एक potentiator है. What is the potentiator one? D is your potentiator, and that is your answer. Cystic fibrosis therapy is costly. Money cannot buy happiness, but money can buy therapy for cystic fibrosis. Always keep it at the back of your mind. Do not chase money, but also chase excellence and make some money ethically, legally. Our profession, medical profession, gives you enough opportunities. Financial stability is what we should always be striving for self and for the family. So question number 13, D. Question number 14, initial drug to start in fluid refractory cold shock in children. I've put this question because I've seen many of you read the older guideline, shock guideline, septic shock guideline, cold shock and hot shock, warm shock guidelines. They have gone changes in the last 2.5 years. Still, many of you are reading the older guidelines. Any shock management, IV fluids are the therapy of choice. After that, you start inotropic agents. In case of cold shock, earlier we used to consider dopamine. Now dopamine is not considered. In case of children beyond neonatal period, if it is cold shock, we go for epinephrine. If it is warm shock, we go for norepinephrine. And so answer to this question is C. This is the table taken from Nelson. Any child comes to you, recognize decreased mental status and children, begin high flow oxygen, establish IO, IV access. So you will obtain access, and then you will start giving 20 ml. After ruling out that there is no fluid overload, you will start giving 20 ml per kg isotonic saline boluses. Normal saline boluses 20 ml per kg. 3 बार दे सकते हैं, that is up to 60 ml per kg. You will correct hypoglycemia, hypocalcemia, begin antibiotics if it is septic shock. If there is no response, you call it as fluid refractory shock. What is the first agent to start? You will consider preferably epinephrine in the patient, right? So titrate epinephrine for cold shock. In case of norepinephrine, it will be used to reverse warm shock in the patient. Remember, you can write like this: in case of age more than 1 month and child coming to you with shock, first start with IV fluid boluses. Which fluid? Normal saline or ringer lactate. Either of the two can be used. 20 ml per kg. Up to 3 boluses can be given. If there is no response, in case of warm shock, you will be giving norepinephrine as the infusion. Cold shock, you will be giving epinephrine as the infusion date. And only in case of neonates or epinephrine, norepinephrine not available, you will prefer dopamine as the inotropic agent. In all varieties, all ages, IV fluids are the initial therapy of choice, right? Shock detail guidelines, you need to do in details. In my revision program, QRP at Doc Tutorials, I have discussed them in a proper, concise way. Question number 15, most common cause of death in a child between 3 to 6 weeks of illness. It is coronary artery aneurysm. And in coronary artery aneurysm, thrombus formation occurs leading to MI. Remember, myocarditis is the most common complication. But thrombosis of CAA, coronary artery aneurysm, producing MI, leading to MI, this is the most common cause of death. So 2 different types of questions can be asked in Kawasaki disease. Kawasaki disease, what is the most common complication? Myocarditis, most common cause of death. Thrombosis of coronary artery aneurysm. Coronary artery aneurysms are the cause of death, and they appear between 3 to 6 weeks of illness. Kawasaki disease, drug of choice, IVIG, aspirin also added. Question number 16. 4-month-old female infant has generalized hypotonia, small ears, inner apicanthal folds, clinodactyly, wide space first and second toe. This is nothing but sandal gap. Sandal gap, small ear, inner epicanthal folds, clinodactyly, that is curved finger, likely diagnosis, all of them consistent with Down syndrome, trisomy 21. Down syndrome patients have increased risk of developing leukemias, 10 to 100 times more risk depending upon age and depending upon the underlying associated mutations. Leukemias are very common. Overall, most common ALL, less than 3 years of age, AML, more specific AML. These are the points you already know. Remember that Down syndrome children are protected from solid tumors. So neuroblastoma, Wilms tumor, and brain tumors are less commonly seen, or you can say never seen, in a patient with Down syndrome. So malignancies, hematological malignancies, very common. Which malignancies never seen in Down syndrome? It is also called as negative association, protective association. Negative association, protective association. With which condition? It is seen associated with solid tumors, right? Let's go question number 17. All of the following are seen in vitamin D deficient rickets except. So nutritional rickets. What are the points to note? Let us write them down. In vitamin D deficient rickets, serum calcium in the patient is normal or low. Initially, it is low. Later, it becomes normal by the time medical attention comes because of the effect of parathyroid hormone. Serum phosphate in vitamin D deficient rickets is always low. Alkaline phosphatase levels are always high. PTH levels are always high. Why PTH is always high? Secondary hyperparathyroidism is common in such patients. And parathyroid hormone, what it will do is it will decrease urinary calcium excretion, leading to retention of calcium, and that is how the calcium becomes normal in the patient, right? So now look at the option. All of the following are seen in vitamin D deficient rickets. I've said low serum calcium can be seen. Normal serum calcium can be seen. Low serum PTH, no. What you see is high serum PTH and low urine calcium excretion. That is true. So what is the answer to this question? They are asking except. So your answer to this question is C. Additional point. Long-standing untreated severe rickets. What will happen? On ABG. Additional point. Added somewhere. Mild metabolic acidosis can occur. If I am an INI CET examiner, ये तो पढ़ के ही आओगे आप. Already previous year question का part है. What additional I can ask? Mild metabolic acidosis. Why? Again related to PTH. PTH causes renal bicarbonate wasting. Bicarbonate loss increases in the proximal tubule, and so patient develops mild metabolic acidosis. But this occurs only in long-standing untreated severe rickets. Question number 18. It's a one-liner, easy thing. Celiac disease, gluten-sensitive enteropathy. What is the first-line screening investigation? Because many of these patients have IgA immunodeficiency also. So guidelines say you have to check total serum IgA in the patient. And what is the most sensitive investigation as first-line choice? IgA variety of TTG. TTG stands for tissue transglutaminase. And so A is your correct answer. The second best is anti-EMA. These are screening tests. If they ask you which haplotype is associated, HLA-DQ2 is most commonly associated, followed by HLA-DQ8. And investigation of choice will always be endoscopy and biopsy. Biopsy will show you subtotal to total villus atrophy, increase in the crypts of Lieberkühn, and intraepithelial lymphocytic infiltration. There is a Marsh grading that you might have read in pathology that is useful. The only treatment for celiac disease is gluten-free diet. These patients are allergic to gluten. If you are allergic to something, you have to avoid that. If you are allergic to someone, you have to avoid him or her. That is the only therapy possible. So celiac disease, it's a older repeat question. The answer has changed. That is why I am discussing here. Older question, if you have practiced it, older AIMS question before INI CET came, it had only total serum IgA, it had only IgA TTG mentioned, but now guidelines say you have to check total serum IgA alongside it. Okay. Question number 19. Look at the following statements regarding febrile seizure in a child. Febrile seizure, high fever causes generalized self-limited seizure is called as febrile seizure. Mostly simple febrile seizure, rarely they can be focal or long-standing seizure. We call them as complex febrile seizure. Let us look at the options one by one. This is a topic you must read in details. Must read in details. So please read in details if you get time during revision. So mostly they occur between the age group of 6 months to 60 months. It is a true statement. Positive family history may be seen. We don't know the cause, but tends to run in the family. True statement. Early age of onset is a risk factor for future epilepsy. False statement. I will come to this point. EEG is always indicated in first episode of febrile seizure. False. First episode of simple febrile seizure, EEG is not done. Even if you do it, normal CT, normal EEG, normal MRI. Continuous prophylaxis using anti-epileptics is not indicated in most febrile seizure is a true statement. It is a self-limited seizure disorder. It is not epilepsy. So there is no need to give continuous daily basis anti-epileptic drugs. So what are the correct options? 1, 2, and 5. 1, 2, and 5. They have mentioned it like this, A, B, C, D. Actually, it should be 1, 2, 5. So अगर इसको A ले, इसको B ले, C, D, E. So it will be 1, 2, 5. A, B, E. C is your correct answer. Right? So it was, I think, a printing mistake. I hope you get the correct, right? The same question nahi aane wala, but you need to understand. So febrile seizure, what are the key points to understand? 2 points I want to emphasize. In case of febrile seizure, they are seizures produced, generalized seizures produced when there is high fever. Age group 6 months to 5 years is the age group in which they maximally occur. Some books say 6 months to 6 years, that is also correct. And most patients, they stop having seizure by 5 years of age. If the age of onset is less than 1 year of age, or there is a short duration fever before seizure is precipitated, these patients have high risk of recurrence. Recurrence means every time there is a high fever, the child will have seizure. But if there is focal febrile seizure, or complex febrile seizure of other varieties, or there is neurodevelopmental abnormalities, or patient is having recurrent febrile seizure, or there is a positive family history of epilepsy. These are the conditions which will increase risk of epilepsy in later life. The parents will ask you, क्या ये बार बार होगा? That is recurrence they are asking. क्या it will turn into epilepsy in later life? These are the risk factor for epilepsy. There are tables given in my quick revision program 5.0 at Doc Tutorials. I have taken Nelson tables and described them in details, because the table discussion and understanding those tables takes almost 15 minutes, which is not possible in this short session. So if you have time, if you can get access to that, you can always have a look. In case you are not following Doc Tutorial, it's still fine. Your study material has to have. If it doesn't have, find it somewhere. You can always ask me. You can always get back to me on Instagram. Read those tables. This is the summary of those tables I'm telling you. So age of onset is a risk factor for recurrence, but not for future epilepsy. C option क्या कह रहा था? Early age of onset is a risk factor for future epilepsy. No, early age of onset is a risk factor for recurrence. And what do you do in the patient? Intermittent prophylaxis. Intermittent prophylaxis is given using benzodiazepine. So intermittent prophylaxis is given using benzodiazepine. That is, only during febrile illness, intermittently you give for 5 days and then you stop it. And after 5 years of age, no therapy needs to be given. No continuous prophylaxis is needed in the patient. Finally, last topic. Question number 20. A 3-week female child has suspected CAH. She has hypernatremia, hypokalemia, and hypertension. She was also noted to have clitoromegaly and fusion of the labia. What is the likely diagnosis? Congenital adrenal hyperplasia, how to approach? Let us look at a quick fire approach. There are 2 ways to approach this question. One way is the usual way. You read the entire physiology charts, remember them precisely, then you try to think which block will cause which problem. This is the normal life. We have aam zindagi. Then you have the flowchart based approach, which is the smart, the Mentos zindagi, the Mentos life that I'll be discussing with you, right? This will help you in solving most of the MCQs. I will just give you an overview. What is congenital adrenal hyperplasia? Congenital adrenal gland has 2 parts, cortex and medulla. Cortex has 3 layers, zona glomerulosa, fasciculatus, reticularis. These layers are involved with formation of glucocorticoid like cortisol, mineralocorticoid like aldosterone, there are others also, and sex hormones. Any enzyme deficiency of one layer causes involvement of all the 3 layers. This is called as CAH. If the enzyme is deficient, why are we calling it as hyperplasia? Because all the varieties have partial or complete deficiency of glucocorticoid. And so ECTH feedback inhibition is lost. All varieties have excess ACTH, and high ACTH causes gland to become large, hyperplastic gland. Hyperplastic gland, size बड़ा है, काम नहीं कर रहा है. That is adrenal gland dysfunction. This is called as congenital adrenal hyperplasia. So look at the topic. It is a group of. I wish I had more time with all of you and wish I could take it in a more interactive way. But nonetheless, let's finish. A group of autosomal recessive condition. मैंने already क्यों लगाया है? It's already a previous year question. What is the type of inheritance? Autosomal recessive. Deficiency of enzymes involved in adrenocortical hormone synthesis. 4 broad types. They have subtypes also. We'll not go into subtypes. Four subtypes are there. First is 21 hydroxylase deficiency, most common, seen in 90% patients. Second is 11 beta hydroxylase deficiency, second most common, 4 to 8% cases. Third is 17 alpha hydroxylase deficiency. Fourth is 3 beta hydroxysteroid dehydrogenase deficiency. For the sake of simplicity, I will only be taking their nicknames. 21H, 11 beta, 17 alpha, and 3 beta. Okay, full form you can read later. Common feature, सभी CH में क्या होगा? Hypoglycemia, hyperpigmentation, because all varieties will have decreased cortisol and increased ACTH. This discussion will make more sense to you if you have already done the topic of CAH. If you have already done, this will be the icing on the cake to get you to correct answer. Okay, so common feature, सब में क्या होगा? Hypoglycemia, hyperpigmentation. Then second thing, what is the type of crisis? These children never come happily to the hospital. They always are brought in emergency. Two types of crisis can occur: salt wasting, salt retaining. Salt wasting will have deficiency of mineralocorticoid. Wasting, salt is getting lost, less aldosterone, less mineralocorticoid. So they will have hyponatremia, hyperkalemia, and shock with dehydration. And salt retaining crisis will be excess of mineralocorticoid. They will have hypernatremia, hypokalemia, and hypertension. And then the genitalia in the patient can either be normal. If male has androgen excess, normal genitalia, just precocious puberty can occur. Male with female hormone, he will have ambiguous genitalia. Female with female hormone, normal genitalia. Female with male hormone, ambiguous genitalia. What is ambiguous genitalia? It was previously called a pseudo-hermaphrodite. Male with micropenis, female with clitoromegaly. Got it? So XY, but male having a small penis, and splitting of these undescended testes with splitting of the scrotum. It will look like a female genitalia. That is called as ambiguous genitalia in male. What will be female with ambiguous genitalia? Have female XX, but she has clitoromegaly and fusion of the labioscrotal fold. That will be ambiguous genitalia in female. Okay. Now, these are the clinical features. How to solve the question? Suppose you get a CAH question like has been shown. First of all, look at the crisis. पहला step क्या है? This is the first step. Never jump to the second step पहला. First step, look at the crisis. If it is salt wasting crisis, two possibility. या तो 21H या 3 beta. If it is salt retaining, either 11 beta or 17 alpha, two options are ruled out. Then you look at genitalia. Male versus female. Male will be XY, female will be XS. Male with normal, male with ambiguous. Female with normal, female with ambiguous. Initially, you may find it tough, but if you make this flowchart 2 times and revise it, it will be a piece of cake for you. I have done my MD from PGI. I've cracked this INI CET. It was not called as INI CET. We had separate exams. AIMS alag, PGI alag, JIPMER alag. I gave all these exams. JIPMER I did not give due to my personal reason. They were separate exams, and I qualified both AIMS and PGI. My rank in PGI was way better. And regional AIMS were not that prominent at that time. So by choice, and because I belong to Chandigarh, I took up PGI exam. And I noticed one thing, that people who crack INI CET, it is not necessary all of them are having a very high IQ or where they are gold medalist in there. No. People who crack INI CET, I realized they do smart study. They focus on the things which are often asked, and they increase their accuracy in these topics on a very high basis. INI CET topic repeats are more. Smart study, flowchart based approach works. Routine ऐसा पढ़ते जा रहे हैं, that works for NEET PG, but that is a problematic thing for INI CET. So still time left. Focus on previous year topics, and this topic, short stature topic, milestone, nutritional indices. Please get that accuracy going. Similar for other subjects. And even if you have been an average student in your MBBS, no doctor is average, but even if you have been, give your best shot. You just might never know. One example is in front of you. I was a smart kid, but okay kid in my MBBS. But when the time came INI CET, a bit of luck, a bit of preparation, and a bit of smart MCQ approach was enough. If it is your day, you will get into a branch of your choice. So you're not out till the actual results are out. Okay, so give your best shot, follow this flow chart if you have already read it. तो क्या करेंगे पहले, मैंने इसलिए बोला so that you absorb this knowledge. Too much of information I'm giving it to you. CAH, first look at the crisis. Salt wasting, salt retaining. Salt wasting, two possibility 21 and 3. Salt retaining, two possibility 11 and 17. Then you look at genitalia. If you look at this flow chart, 3 beta always causes ambiguous genitalia, चाहे male में चाहे female. 21, 11 stay together. They cause normal genitalia in male and ambiguous in female. 17 causes normal in female and ambiguous in case of male. And you apply this approach, you will get your answer. Applying this approach into your MCQ, let us go look at the MCQ. MCQ is saying female child. She has hypernatremia, hypokalemia, hypertension. What is the type of crisis? This is salt retaining crisis. So salt retaining crisis means she has either 21 is ruled out, 3 is ruled out. So she has either 11 or 17 alpha. Now look at the genitalia. Female with clitoromegaly and fusion of labia. So she has ambiguous genitalia. Ambiguous genitalia. 17 will be ruled out. 17 alpha cannot be the cause because 17 will cause, have a look here, 17 will cause normal genitalia in a female. Can you see it here? It will cause normal genitalia in a female. So what are we left with? 17 is ruled out. 11 beta hydroxylase deficiency is your answer. Take some time to think. Sometimes male, sometimes female. Sometimes salt bursting, sometimes salt retaining. Sometimes normal genitalia, sometimes ambiguous genitalia. Apply this flow chart and most of the cases you will get the answer correct. Just try it in your pre-YQs. Just try it in some of the questions and see if it works or not. It may not work for you if you already know the topic. Great, continue with that. But if you find this topic tough, just apply because getting answer correct is more important in MCQs. Concepts are needed, but smart approach is also needed, right? So if you have any academic queries, any doubts, you can scan this there on Instagram. Reach out to me, and time was limited, and I hope all of you do well. And let's support our country in this tough time. We are there with the country, and let's do our work. And hopefully, we'll come out of this entire thing stronger, better. And may all of you be healthy and take care of your health and take care of your family in this tough time. And stay away from negative news, stay away from fake news. Okay, take care. Bye-bye. Rakesh, you can stop the session.